Hello, this is Dr. Ajinkya. Today we have a CT scan of a patient complaining of right side nasal cavity clear watery discharge since 6 months. So we got a CT scan done, and this CT scan shows a prominent defect in the cribriform area in the olfactory region, and the beta 2 trace protein results were also positive. So this is a case of a CSF leak from right side nasal cavity, and on diagnosis the scans were showing a prominent cribriform area leak. This is the cribriform plate, that's the olfactory fossa in the anterior ethmoid region, that is the anterior to the ground lamella. So you can prominently see this is a brain tissue over here, and you can see this continuation of the soft tissue density right from the brain intracranial cavity into the nasal cavity. See this? That's the breach in the olfactory cribriform region. So today I'll be showing you how in simple steps you can read the CT PNS right from the first scan up here next to the Gantry View right up till the last scan, which is the posterior most aspect of the anterior cranial fossa and the middle cranial fossa region. So before ordering a CT scan for any patient, or when you're operating on a patient for a sinus surgery or a skull base surgery, it is very important, as I always say, the thickness of the scan matters a lot. Normally the range which the surgeons used to order the CT scan at was a range of 3 to 5 mm, but a lot of important information used to be missed out on those thickness CT scans. So the trend today is around to order a 1 mm scan, which is the most ideal thickness for any CT PNS scan to visualize all the important neurovascular structures surrounding the sinus area. So this scan, what we have here, is a 2 mm scan, coronal section. So I normally aim to teach students first the basics in the coronal section. Once you are well acquainted with the coronal, we'll move on to the axial and the sagittal sections. So also after the thickness of the CT scan, the second most important point for any CT scan is the views. The surgeon should order the CT scans in all the three views, which is the coronal, sagittal and the axial, because certain anatomy is well defined in the coronals, certain anatomy is well defined in the sagittal and the axial as well. So to start with, I'll begin with the CT scan coronal section. The first view, the image which you see here, this image is always present in a CT scan. The first box, this is called as the Gantry View of the CT scan. The Gantry View is the view in which the patient lies in the CT scan for the scan. So that's called as the Gantry View. So as you can see, there are no lines in this. It's a simple front view of the patient's bony anatomy. So this is a position resembling the area in which the patient is lying in the gantry. That is a CT scan machine. If this image is not there, there could be one more image where the patient's skull is seen in the lateral aspect, and a lot of vertical lines can be seen passing through the skull at specific intervals of thickness. That film then is called as the scout view. So the scout view is nothing but the view in which it shows in what position and in what thickness intervals the scans were taken. For example, this scan is a 2 mm scan, so you can see all these different lines passing at equal intervals of 2 mm from anterior to the posterior. So as I was saying, let's move on to the first image over here. So this scan is completely of a coronal section scan. As you can see here, this is completely a coronal section scan, right from the anterior to the posterior aspect. So to begin with, this was a gantry view, and the first image, as you can see here, this bright white structure, as you can see, is the frontal bone. This area is the frontal bone over here. What you can see here is the left frontal sinus, the right frontal sinus. So whatever you see black on the CT scan is considered to be as air, because air appears to be as black on the scans. So This structure over here is the frontal bone. This is the left frontal sinus. This is a right frontal sinus. And as you can see, between these two sinuses is the septa. That's called as the interfrontal sinus septa. As you go below, you can see the two processes. This is the frontal process of the maxilla. As you go behind, you can see this is a nasal bone over here, and the two elongated processes as we go behind turns out to be the frontal process of the maxilla. So you can prominently see here, that's the area of the nasal bone. So the nasal bone and the frontal bone, and in between you can see a small fine suture. That's the junction of the nasal bone with the frontal bone. So the frontal sinuses, as we go from the anterior aspect to the posterior aspect, the sinus size keeps on getting bigger. So as you can compare from the first scan over here, the size of the frontal sinus keeps on getting bigger. The frontal process of the maxilla also keeps on getting lengthier. Okay, so this you can see is the nasal bone, that's the frontal bone, that's the junction between them. With the help of a suture, it gets attached to each other. This white structure you see just below the nasal bone, that's the perpendicular plate of the ethmoid, and with this area you can see that's the septal cartilage. So as you go from anterior to posterior, you initially see only the septal cartilage. You will not see any bony structure. So this is a septal cartilage entirely from the upper to the lower aspect, but as you keep on going posteriorly, you start seeing a small segment of the perpendicular plate of the ethmoid, and this is a septal cartilage. This patient has a slight deviation to the right side, and these two structures you can see are the nasal ala. These are the nasal ala. So as you keep going posteriorly, the same structures you can see, they just become more prominent on the CT scan. Here I would like to get your attention on this cell. What we can see here was the interfrontal sinus septa, and this area you see, it is pneumatized. The interfrontal sinus septa is pneumatized and forming a cell-like structure within. That is called as the interfrontal sinus septal cell. And you can see there is one more intrasinus septa on the right side. This is a nasal bone, that's the frontal beak at the floor of the frontal sinus. You can see there's a two separate nasal bones fusing with the frontal bone, and this is a frontal beak. This is the frontonasal process of maxilla, the perpendicular plate of the ethmoid, the septal cartilage. As we further keep on going behind, the structure of the interfrontal sinus cell over here, as you can see, it was initially small, it has increased in size, and it has formed a complete huge cell. So that's the interfrontal sinus septal cell. Now the thing which we are interested in here is that in which sinus does this cell open into, whether it's the left or the right. Studies suggest that the side into which the interfrontal sinus cell opens up is the dominant sinus of the patient. So here you can see the anterior nasal spine appearing. That is the attachment of the anterior most area of the maxillary crest up to the septal cartilage, and that's the perpendicular plate of the ethmoid you can see. So this is the interfrontal sinus septal cell. As moving further posteriorly, you can see this is the interfrontal sinus septal cell opening up into the right frontal sinus. You see this? Now this becomes the interfrontal sinus septa, with this wall becoming interrupted in between. So this is the proper interfrontal sinus septum here. This was the cell which opened up in the right frontal sinus, and you can see a prominent area of the frontal beak which forms the floor and the anterior wall of the frontal sinus on both sides. In continuation, there is a frontal process of the maxilla, and that's the perpendicular plate of the ethmoid, the septal cartilage, the maxillary crest, the maxillary bone. So, as we go further behind, there's a new structure which has appeared right here. Okay, so this is the frontal nasal process of the maxilla. That's the perpendicular plate of the ethmoid, the septal cartilage, the maxillary bone, the frontal sinus. Now, all these scans which we have seen so far, the floor of the frontal sinus was intact. Nowhere we could see any breach in the sinus floor. So we can assume this structure to still be the frontal sinus area. Once the floor of the frontal sinus is not seen, that becomes the area of the frontal recess. See, up till this scan, the floor was completely intact. This formed by the frontal beak on both the sides. As we go one scan behind, see, the frontal sinus floor is completely absent. So this area becomes the area of the frontal recess. So once the floor of the frontal sinus disappears, that officially marks the beginning of the area of the frontal recess. So right from here, right from this scan, okay, just keep a look on the frontal sinus floor. Right from this scan to this scan, just keep on following. You will see in all these scans, the frontal sinus floor is completely intact, which is formed by the beak. The moment you go one single scan behind, the frontal sinus floor disappears. This marks the beginning of the frontal recess area. So this is a frontal beak. The next scan is a frontal recess area, and exactly below this region you see these two pneumatization cells. These two cells over here, these are the agar nasi cells. Okay, now what is agar nasi? Agar nasi is nothing but the anterior ethmoidal cell which pneumatizes the lacrimal bone near the area of the nasolacrimal duct system. So this is the beginning of the agar nasi cell. That's the perpendicular plate of the ethmoid. That's the septal cartilage, the maxillary bone. That's the inferior turbinate into the picture. You can see here, that's the inferior turbinate, which was not seen up till now. So the inferior turbinate has come into the picture on both the sides. A little bogginess in the nasal septal area. That's the appearance of the agar nasi cells on both the sides. That's the frontal sinus area. This is a frontal recess area, as there is no frontal floor, no beak in this region. And you can see this, that just follow the agar nasi. This is the agar nasi cell. Just keep on following these two cells. So as we all know, agar nasi forms the anterior boundary of the frontal recess, and the bulla ethmoidalis forms the posterior boundary of the frontal recess. So in 95% of patients, we see positive agar nasi cells. Only in few cases the agar nasi may be absent. So that's the agar nasi cell. Keep on following the agar nasi. Here you can see this is the agar nasi cell anterior to the frontal recess area. So you can see one more cell up here right above the agar nasi cell. Now that being present in the frontal recess area. This area is the posterior most aspect of the frontal sinus, and this officially is the area of the frontal recess. This was frontal sinus proper. This is the posterior most aspect of the sinus, and that's the frontal recess. That's the agar nasi cell on both sides, and as you can see, there's one cell above the level of the agar nasi. That could be frontal cone type 1 cell. You see this? That's the prominent agar nasi and one cell above the level of the agar nasi on both the sides. So this is a case of a frontal type 1 Kuhn cell. That is there was a surgeon called as Kuhn who gave the classifications of the frontoethmoid cells. So whatever cells which can block the frontal recess from the anterior aspect, Kuhn gave a classification which included 4 types, in which type 1 suggested that there is presence of one single pneumatized cell above the level of the agar nasi. In type 2, so you can see there's one single cell above the agar nasi. So this is type 1 Kuhn. In type 2, there are presence of 2 or more type of pneumatization cells above the level of the agar nasi. So it is very important to keep your agar nasi in view always. So that's the basic thing. Once you locate your agar nasi, just look if there are any other cells above the level of it. So depending on the number, you can just classify them. As you can see here, there's a single cell above. So this becomes frontal type 1 Kuhn. Then in case of frontal type 3 Kuhn, there is presence of a single large pneumatized cell above the level of the frontal beak. Now, as you can see here, that's the level of the frontal beak. Okay, that's the level of the frontal beak. As you go behind, there is no beak, which marks the beginning of the frontal recess. So this is the rough area of the frontal beak, beyond which the ostia starts and then the sinus proper above. So if there is a particular large pneumatized cell, single pneumatized cell, the cell which being at the level of the frontal recess, in the level of the frontal recess, and above is the frontal sinus. So type 3 Kuhn is presence of a single large well pneumatized cell above the level of the beak. So you can see this is the level of the beak. So above the level of the beak, but less than 50% of the length of the frontal sinus in total. That is frontal type 3 Kuhn cell. Now frontal type 4 Kuhn cell is a pneumatized single cell well within the frontal sinus, above the level of frontal beak, and more than 50% length of the frontal sinus. So it is also called as an isolated cell somewhere lateralized into the frontal sinus. So that becomes type 4 Kuhn cell. Here we have a case of a type 1 Kuhn cell. So we studied so far the relationship of the frontal sinus, the interfrontal sinus septa, the interfrontal sinus septal cell, which is opening here in this case on the right side, and then the relationship of the agar nasi. Depending on the pneumatization above the agar nasi, we classify Kuhn's frontoethmoidal cells. Also, we studied the relationship of the frontal sinus to the frontal recess depending on the frontal beak presence. So moving behind, this is the area of the agar nasi, and here we see the beginning of the nasolacrimal duct system. You see this region? That's the anterior most area of the beginning of the nasolacrimal duct system. Okay, so wherever region you see agar nasi, just around it should be the area of the nasolacrimal duct system. Now that's the nasolacrimal duct system area, which is the most anterior part of it. As you keep on going behind, keep in mind this is a 2 mm scan, so there's a slight chance that a bit of the segment may get skipped in between. So as you go one scan behind, this is the area of the nasolacrimal duct system. As you go one scan behind, it keeps on getting prominent. You see this? That's the area of the nasolacrimal duct system. Now, the nasolacrimal duct, this is the area of the orbit, the globe. Roughly, this could be the upper canaliculus. This is the lower canaliculus, common canaliculus, which drains into the lacrimal sac area. The sac continues as the nasolacrimal duct. The nasolacrimal duct opening into the inferior meatus. Now see, this is the inferior turbinate. You see, that's the inferior turbinate. And this area, the black shadow you can see. And this is the lateral wall. This is the inferior turbinate. So in between there is this inferior meatus. Now the inferior meatus hosts the opening of the nasolacrimal duct, which is around 1.5 centimeters posterior to the anterior most end of the inferior turbinate. So in surgery, while you're operating, if you take a Freer's elevator and put it under the inferior turbinate in the inferior meatus and lift it up, you can see the opening of the nasolacrimal duct 1.5 centimeters behind the anterior end of the inferior turbinate. So that's the region. So how you can identify the nasolacrimal duct system in a coronal view is to first locate the agar nasi cell. And how do you locate the agar nasi cell? Is the agar nasi cell the moment you see the frontal process of maxilla. Now, as I showed you in all the scans over here, this is the frontal process of the maxilla. Once you start seeing the frontal process of the maxilla, keep on following it. See, I'll make it simple for you. That's the frontal process of the maxilla, frontonasal process of the maxilla. Just keep on following that frontal process of the maxilla until you see a pneumatization. See here, what you see, the first cell or the first pneumatization when we follow the frontal process of the maxilla is the agar nasi cell. These two agar nasi cells, keeping them in view always, keep on following them for the relationship of the frontal recess and the cone type of frontoethmoid cells. In this very region starts the area of the nasolacrimal duct system. See this? That's the area of the nasolacrimal duct system. Keep on following it. So in this scan, see this prominent nasolacrimal duct system. So in this scan, it is not visible. So it was visible in these three scans. That's the very beginning of it. Keep on following it. That's the nasolacrimal duct. See this? That's the nasolacrimal duct opening into the inferior meatus. So these three scans shows us the area of the nasolacrimal duct clearly. So there are two basic principles for nasolacrimal duct visualization. You need to see the agar nasi first, and for the agar nasi first, you see the frontal nasal process of the maxilla. The very first pneumatization in that very bony region is your agar nasi, and once you see the agar nasi, you can have two things. First, you can know the area of the frontal recess, whether it is having any frontoethmoid cone type cells, or the second thing, with the help of the very same agar nasi, you can identify the nasolacrimal duct system. It's a bit hypodense area as compared to the surrounding tissues over here. So also, we get to know this is type 1 cone frontoethmoid cell. Now, what is the significance of this frontoethmoid cone cells over the area of the frontal recess? Now, as I said, the agar nasi is anterior to the frontal recess. Similarly, the frontoethmoid cone type cells are also anterior to the frontal recess. So if they are well pneumatized, they can block the frontal recess drainage anteriorly. So while doing a surgery, it becomes very important to read the CT scan and remove those cells while clearing off the drainage pathway for frontal sinus. If you don't, the frontal sinus will remain blocked and it will keep on getting recurrent episodes of sinusitis. So once you're doing a surgery, it is very important for the surgeon to read the scan and open up these cells while doing the surgery. So we so far have studied the frontal sinus, the frontal recess, the Kuhn type cells, the agarnesi, the frontal process of the maxilla, how to identify the agarnesi, and with that very same agarnesi, how to identify the Kuhn type cells and the area of the nasolacrimal duct system. Now this is a drainage pathway of the nasolacrimal duct through the Hasner's valve towards the inferior meatus. So there are two more structures very important happening in this very scan over here. See this scan? There are two more important structures happening over here. See, in all these scans, we cannot see the opening of the maxillary sinus. Okay, as we go on posteriorly, now in this scan, see over here, this is the area of the opening of the maxillary sinus. That's the area of the maxillary sinus. This is the anterior most aspect of the maxillary sinus. As we keep on going behind, you can see the maxillary sinus becoming more prominent and triangular in shape. Okay, so far as we go up to the ground lamella, which is the middle 1/3 of the turbinate, the middle turbinate, the maxillary sinus will remain triangular in shape and keep on becoming bigger in size. But once we enter into the posterior ethmoids, the very same maxilla starts becoming oval in shape and narrow. See, you can see it is becoming oval in shape and becomes narrow, and eventually it disappears. That's it, it disappears. So I'll come to that point again in some time, what other changes in the sinus areas once you cross the anterior through the ground lamella into the posterior ethmoids. So this is the area where the maxillary sinus starts. That is the anterior most region. That's the agar, that's type 1 Kuhn, that's the skull base, that's the frontal bone, that's the skull base, that's the medial orbital wall, that's the lamina papyracea, the most thinnest structure in the orbit. The name itself is lamina papyracea, which suggests it's paper thin, very much prone to the injury while doing a maxillotomy. This is the nasolacrimal duct system area. That's the beginning of the maxillary sinus, the inferior turbinate, the inferior meatus. Now, if you closely look, the middle turbinate is nowhere in the picture so far. What we could see is the inferior turbinate only. The middle turbinate has not come into picture so far. So if you keep on going posteriorly now, in this scan, there are two findings right here. One is the appearance of the Crista Galli on the superior aspect. That's the triangular diamond shaped structure is Crista Galli. And the second thing is this is the middle turbinate. You see this? That's the middle turbinate. This is the beginning of the middle turbinate. So in this scan, there is presence of the Crista Galli and the middle turbinate into picture. That's the middle turbinate. Let's start with the Crista Galli. Crista Galli is a part of the ethmoidal labyrinth, the ethmoidal bone. The Crista Galli also officially marks the beginning of the anterior cribriform area, that is the anterior skull base. And this Crista Galli gives a firm attachment to the falx cerebri in the midlane. That is the intracranial cavity. This falx cerebri is attached to this Crista Galli. Now, coming to the middle turbinate. Now, middle turbinate has three parts: the anterior, middle, and the posterior 1/3. Middle turbinate is the anterior 1/3 having an attachment. Now, the first part of the middle turbinate you see over here has an attachment to the junction of the lateral lamella of the cribriform to the medial lamella over here. Now, the cribriform plate has two lamellas. The vertical, you see this thick white vertical structure, that's the lateral lamella, and a small bony area over here, that's the medial lamella. The very junction of these two hosts the attachment of the middle turbinate anterior most 1/3 part. So when in surgery you're handling the middle turbinate, you always have to make sure that it's not too harsh. Otherwise, this very attachment over the skull base is kind of delicate. If it gets injured, there's a good chance there will be a CSF leak. So, while the young surgeons or those who are new to the sinus surgery, you always make sure you never handle the middle turbinate in its anterior 1/3 part very harshly. Otherwise, it could lead to a CSF leak. So second point is that also when you do a bulgarization technique for the middle turbinate in the post-op or in case when the surgery is about to end, always make sure you suture the middle turbinate in its lower 1/3 aspect in the anterior 1/3 area. If you try to suture it high above, first thing, it is going to block. See this? That's the middle turbinate. Bulgarization should be done at this level with the septum. This is a septum and this is a middle turbinate. This is the area where the bulgarization should occur, not high up. If we bulgarize it high up, this is the area of the olfactory epithelium. It will lead to blockage of the airflow and lead to hyposmia or anosmia. And second thing, if you handle it too high up, it will lead to a CSF leak following a trauma. So this was the anterior 1/3 attachment of the middle turbinate. As we go behind, see this? Follow this middle turbinate. It is still attached to the cribriform. This is a middle turbinate still attached to the cribriform. Keep on following that middle turbinate. See this? That's the middle turbinate still attached to the cribriform. That's the middle turbinate still attached to the cribriform. Still the same to the cribriform. It is still attached to the cribriform. But in this region, you start to see some small attachments over here. The main attachment being to the cribriform, but few small attachments you can see coming here going to the lamina papyracea. This marks the very most anterior aspect of the ground lamella. So as you keep on going further behind, see this. The middle turbinate is curving and going where? The lamina papyracea. See this? That's the orbit. And that is the medial orbital wall, lamina papyracea. And where is this middle turbinate going? See this? It's going onto the lateral aspect, the medial wall of the orbit, which is the lamina papyracea. This is the area of the ground lamella, which is also the middle 1/3 of the middle turbinate. And see this structure above? What is that? That's the area of the superior turbinate. So once you enter into the posterior ethmoids, immediately behind the ground lamella, you can see the superior turbinate. So I'll visualize this once more. Or if it's a scan of 0.5, a range of 0.5 to 1 mm, this in some cases could be the posterior most attachment of the middle 1/3, anterior 1/3, and this is the attachment of the middle 1/3. So this could be the attachment of the posterior most aspect of the anterior 1/3 of the middle turbinate, and this is the proper ground lamella, that is the middle 1/3 attachment. So if you go one scan behind, see this? This is the middle turbinate with the attachment. Now there are two different attachments here. If I go back here, you see both these attachments are on the lamina papyracea. See, this is the lamina papyracea. Both the attachments are on the lamina. So this is the proper middle turbinate 1/3, middle 1/3. That's the ground lamella. If you go one scan behind, this is a 2 mm scan. If you go one scan behind, see this? There is one attachment onto the lamina papyracea, but look at the lower attachment. See, it's curving downwards. And what is this? That's the medial wall of the maxilla now. And what is that formed by? That's formed by the perpendicular plate of the palatine bone posteriorly. So this is the perpendicular plate of the palatine bone. So this is having an attachment to the perpendicular plate of the palatine bone. And this is the attachment to the middle 1/3, that is the lamina papyracea. So this marks the end of the ground lamella, and the beginning of the attachment of the posterior 1/3 of the middle turbinate. So one scan behind this, you will be officially completely in the posterior ethmoids. You see this? That's the middle turbinate, and that's completely attached to the medial wall of the maxilla. In this case, it is formed by the perpendicular plate. You see this bony plate? That's perpendicular. That's perpendicular plate of the palatine bone. So that's the posterior 1/3 of the middle turbinate. And see, this is a complete area of the superior turbinate. You see this? This is the complete region of the superior turbinate. So this is a superior turbinate attached to the skull base, posterior skull base, which is thick in nature, as compared to the anterior 1/3 of the middle turbinate, which was here. That's the anterior 1/3 attached to the cribriform. That's very weak in nature, and as compared, this is a superior turbinate. This is a superior turbinate which is attached to the posterior skull base, which is thick. So even in surgery, if you handle the superior turbinate harshly, it is accepted because the skull base is not at all weak over here. It will not lead to CSF leak. But as compared to the anterior 1/3 of the middle turbinate, which is attached to the junction of the lateral and the medial lamella of the cribriform, if you handle it harshly over here while surgery, or while bulgarization, or while by doing microfracturing, this can lead to a damage in the lateral lamella and can give you a CSF leak. Okay, so this is quite a few differences where the turbinates can change in shape and appearance depending on whether you're going from the anterior to the posterior ethmoids. So that was the official beginning of the entire superior turbinate, as I just explained. So this is a superior turbinate, that's the middle turbinate, that's the inferior turbinate, all three turbinates in one single scan and one single view. So this is officially the posterior ethmoidal region. So that was in short the anatomy of the middle turbinate, the anterior, the middle and the posterior 1/3 with their origins, their insertion, and the relationship to various skull-based structures, and the orbital anatomy, that is the lamina papyracea, in respect to the middle turbinate. Now moving to yet another important structure for a sinus surgeon is the osteomeatal complex. Now, what is osteomeatal complex? The OMC. It's the area in which the maxillary sinus drains into. So this was a very scan where we could see the beginning of the maxillary sinus area. Yeah. So as we go posteriorly, the maxillary sinus keeps on getting bigger in size and triangular in shape. This is the inferior turbinate. This is the middle turbinate. That's the Crista Galli. That's the roof. That's the skull base region. That's the anterior cribriform. That's the anterior ethmoidal area. Between the anterior ethmoidal roof and the cribriform, there's a region of fovea. That is the ethmoidal fovea over here, this region. That's the middle turbinate. So when you are studying about, when you're learning about the OMC, that is the osteomeatal complex, few structures constitute the anatomy of the OMC, which is the uncinate process. So as you can see in this scan, that's the inferior turbinate. That's the inferior turbinate. That's the nasolacrimal sac and the duct system. That's the uncinate process. So how to identify, see, first I'll give you the anatomy of the OMC. Now the osteomeatal complex constitutes of three structures: the uncinate process, the bulla ethmoidalis, and the middle turbinate. Okay, so what we have here, this is the uncinate. I'll tell you the entire anatomy of the uncinate, how you see the uncinate on the CT scan, where it origins, where it exits, and where it attaches. The course of the entire uncinate, I'll explain it to you. But first, let us know what makes the OMC. This is the uncinate process over here coming from the inferior turbinate. That's the uncinate process. That's the very beginning of the bulla ethmoidalis. Now, bulla ethmoidalis, as I said, makes the posterior aspect of the frontal recess area. So this was the frontal sinus proper region with the floor intact. This here, there is no floor, that is a frontal recess with the agar nasi, the frontal cone type 1 cell. So as we go posteriorly, you see this agar in the type 1 cone cell. This is a frontal recess area. And as you go further behind, you see that's the very beginning. This cell you can see on the lateral wall of the lamina papyracea, the medial wall of the orbit. You see this area? That's the very start of the bulla ethmoidalis. And if you keep on following the posterior scan, you see this area, it is becoming very huge and one single cell. That's the bulla ethmoidalis. That's the bulla ethmoidalis proper. So this is the uncinate process coming from the inferior turbinate. That's the uncinate process. That's the uncinate process bone. That's the uncinate process. That's the bulla ethmoidalis, the huge cell. The anterior most consistent ethmoidal cell is the bulla ethmoidalis, the bulla. So uncinate, bulla ethmoidalis, and the middle turbinate. 1, 2, 3. These three structure forms the OMC. Okay, these three structures form the OMC, the osteomyelial complex. So now I'll give you a detailed anatomy of the uncinate process. Now, what is uncinate process? Now, if you to make it simple for you, the uncinate process is a boomerang shaped, the only mobile part, that is the only movable part in the lateral wall of the nose. The uncinate has two parts. See, as you can see here, that's the uncinate. This very part from where the uncinate comes or has an attachment to the inferior turbinate over this region is the horizontal process, and going up, you see this, just continue this white structure. You see this, you go up, you go up, you go up. See this? That's the vertical process of the uncinate, just lateral to the middle turbinate. That's the vertical process of the uncinate. So, which is having an attachment to where? Lamina papyracea. So, we all know that the uncinate process has two parts. The horizontal having an attachment to the inferior turbinate in most of the cases, or in some few cases having an attachment to the perpendicular plate of the palatine bone, which is the posterior wall, which is a posterior aspect, the medial wall of the maxilla. So in this case, you can see the attachment is onto the inferior turbinate. It is going, this is a horizontal process, and we go up, 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 getting an attachment on the lamina. That's the vertical process. Now, in the uncinate process, the horizontal portion is fixed. Okay, the horizontal portion is fixed. Only the vertical process is kind of variable in insertion. Now, in 95 to 98% of cases, the uncinate process vertical part goes medial, as you can I can show it to you here. That's the agar nasi. Yeah. See this? That's the horizontal portion. That's the vertical portion going up, up, up to the lamina papyracea. Now, in most cases, the uncinate process vertical portion travels medial. This is the most posterior aspect of the agar nasi and the beginning of the bulla ethmoidalis. Okay, so the vertical process of the uncinate travels. See this? The vertical process travels medial to the agar nasi. In this case, I'll just show it here. This is the uncinate process traveling here. It travels medial to the agar nasi, and then turns laterally to attach to the lamina papyracea. This is the most common anatomy of the vertical process of the uncinate. So in very few cases, where in such rare cases or few cases, this very vertical process of the uncinate, instead of going to the lamina, it directly goes up. See the instrument of mine where it's pointing? Instead of going here onto the lamina, it directly goes up to the skull base, or it can go medially onto the middle turbinate. See here, it's just right next to it. It can go to the middle turbinate. In any of these attachments, it can get attached to either the skull base or the middle turbinate. So why I'm stressing so much on the insertion of the uncinate process is that when you are opening a frontal sinus, okay, it is very important to remove the entire vertical process of the uncinate. As I have shown in the previous video of me operating a FES patient, I have shown each and every step and how to improve the anatomy, the opening of the frontal sinus, where I have removed a type 3 Kuhn cell and the agar nasi and the entire uncinate process. So if the uncinate process, as in this case being attached to the lamina papyracea, as in this case being attached to the lamina papyracea over here, see the front, this is a frontal recess area, the posterior most aspect of the recess area. So I'll show you on this scan. That's the area of the frontal recess. So if the uncinate is attached to the lamina papyracea, the frontal recess will drain medial to the uncinate process and into the middle meatus. This area, see, this is a middle turbinate, this is a middle turbinate over here, lateral to it is a middle meatus. So if the common anatomy like this we have, if it is attached to the lamina, the frontal recess, the frontal sinus will drain medial to the uncinate, that is into the middle meatus. But if this vertical process is attached to the cribriform here or to the middle turbinate here, so see, follow my instrument, the insertion will be like this over here. See, this will be the insertion like this. So the frontal sinus will drain from here. The insertion is like this, and see at the frontal recess, it will drain from here then into where? This is the infundibulum laterally. So this is having the significance of the uncinate attachment. So depending on the uncinate attachment, it becomes very easy for the surgeon to open up the frontal sinus without any complications. So that was the anatomy of the uncinate process. Now, you see the very beginning of the bulla ethmoidalis. This is a bulla ethmoidalis proper over here, the big huge cell. Now, you see this? That is the inferior turbinate, that's the inferior turbinate bone. That's the uncinate horizontal, that's the uncinate vertical attached to lamina. So the frontal recess is draining medial to the uncinate, that is into the middle meatus and then the nose and then the nasopharynx. So pretty easy and common anatomy of drainage of the frontonasal duct. Now, this is the uncinate, vertical and horizontal, and see this area? This is the area of the bulla ethmoidalis. Look carefully now. The area between the bulla, this entire structure is the bulla ethmoidalis, and this is the uncinate. So while opening the first step in a maxilla, we have to do a uncinatomy. So you break the uncinate in the horizontal portion and you access into the area which I'm pointing right now. That is the area between the bulla ethmoidalis and the uncinate. That is called as the hiatus semilunaris inferioris. This black shadow in between you see, that's the hiatus semilunaris inferioris, which opens into a three-dimensional space called as the infundibulum, and that leads into the maxillary sinus. That leads into the maxillary sinus. So that was the osteomeatal complex for you, the uncinate, the middle turbinate, and the bulla ethmoidalis. The space where I showed you right now, this area, this black shadow area, this area, that's the hiatus semilunaris inferioris between the uncinate and the bulla, which is a two-dimensional space draining into a three-dimensional space, which is the drainage area of the maxillary sinus. See, what I can see here is a small halar cell, a very small halar cell. You can see here, that is kind of affecting the area of the infundibulum. This area, see this black cell, small black cell, this area, see this area, that's the halar cell. Now what is a halar cell? This is the halar cell over here, very small halar cell, see, affecting the area of the infundibulum slightly. So we need to open that area while surgery so that the area of the infundibulum widens even more further. That's the Haller cell, a very small one. Now what is a Haller cell? Haller cell is nothing but the pneumatized ethmoidal cell into the infraorbital region. See, this is the orbit, that's the infraorbital region. A very small cell though. So that was the anatomy of the osteomeatal complex, or the OMC. And yeah, so one more thing. So see, as we are going posteriorly, we can see this area of the cribriform, the olfactory fossa, the Crista Galli, the olfactory fossa. And see, at this area, you will see the leak occurring. See, that's the brain tissue. This entire thing is the brain. That's brain. Okay, that is skull base. See, as we move inferiorly, this is the area of the medial lamella of the cribriform. That's the center of the Crista Galli, most posterior aspect. That's the lateral lamella vertical plate. That's the lateral lamella vertical plate. The entire vertical plate is the lateral lamella. See this white structure vertical, that's the entire lateral lamella. That's the middle turbinate. So how to locate the medial lamella of the olfactory region? That is the cribriform plate. So as I said before, the middle turbinate attaches to the junction of the lateral and the medial lamella. So see this junction, lateral to it is all the lateral lamella, and medial to it is the medial lamella. So on the right side, you can see the entire medial lamella is destroyed over here. So whatever brain meningeal layers are getting prolapsed into the nasal ethmoidal cavity, medial to the middle turbinate and lateral to the septum, through this defect in the medial lamella of the cribriform. Okay, so this is how you identify the site of the leak, and this is going beyond posteriorly. See this area? That's the brain tissue. That's the prolapse of the brain meningeal layers. See this? That's the opposite side, beginning of the superior turbinate. That's the center point. That's the septum. That's the medial lamella. That's the lateral lamella. That's the medial lamella being destroyed over here, the lateral lamella being intact. So the entire medial lamella is gone, and that's the leak we can see here. So so to better understand the anatomy even furthermore in the cribriform area, you need to understand what Quiros classification is. Now, what is Quiros classification? Quiros classification, there was this guy called as Quiros who gave this classification of 3 types. Now, Quiros gave the depth of the olfactory fossa depending upon the length of the lateral lamella. So, I'll show you. This is the beginning of the cribriform plate, right? That's the Crista Galli, which marks the beginning of the cribriform plate. That's the middle turbinate, lateral lamella, medial lamella. So you can see here, this is a skull base, above which is the intracranial cavity. So this is a skull base at this level, and that's the medial lamella, that's the lateral lamella. Okay. So how you identify the depth of the olfactory fossa using Quiros classification is that the entire length of the lateral lamella. See this? The lateral lamella is so big here, lengthwise. See the length of the lateral, this entire structure is lateral lamella, which is also called as a vertical lamella because it is vertical in shape. And beyond this is the ethmoidal fovea and the ethmoidal roof of skull base. So it's like in the center, that's the Crista Galli posterior aspect. That's the medial lamella, lateral lamella, fovea ethmoidalis, and the ethmoidal roof. This is how the structures are from medial to lateral. So in this case, you can see the lateral wall or the lateral lamella, the length as compared to the base of the skull, that is the skull base, the level of the medial lamella. See the medial lamella and the lateral lamella, the measurement is from the start point of the lateral lamella to the start point of the medial lamella. That is how you measure the depth, and it is classified in 3 types, type 1, 2 and 3. In type 1, the depth of the olfactory fossa, which is from this level to this level is only 1 to 3 mm, so that the lateral wall lies very low and a very short segment of it, so it is not that much prone for injury. So that is the safest type of Kiros classification, where the cribriform is not prone to injury. In type 2, the depth is about 4 to 7 mm. That is the type 2, which is the most common type of Kiros classification you can ever get. That's the most commonly occurring Kiros type of classification. So, and in type 3, where the length of this entire lateral lamella in respect to this medial lamella, the skull base, is around 8 to 16 mm. It goes up to 1.6 centimeters. You can imagine how the depth will be in that case. And in that case, the lateral lamella is so long, so lengthy, that the entire lateral lamella is exposed for injury, and that becomes the most dangerous type of the Kiros classification. So very much prone for injury, which may lead to CSF leak. So that was Kiros classification for you. By looking at the scan over here, this patient appears to be of Kiros type 2, which lies around 4 to 7 mm. Okay, so that was the Kiros classification for you guys. Now, having known the Kiros classification, the depth of the olfactory fossa, the cribriform area, and where the injury can occur, in which type, which is the most common, then you can understand the area of the cribriform leak happening over here. Okay, so this area is the area where the leak starts. That's the defect in the medial lamella. See the length of the lateral lamella in comparison to the medial lamella. This is a type 2 Kiros classification, which is the most common. And here, see, this is a leak of the meningeal layer into the superior most aspect of the ethmoidal roof. This is the region of the cribriform area, the olfactory fossa. So this patient basically has a cribriform defect into the olfactory fossa region. Okay, so there's one more important anatomy in this very same region, is the anterior ethmoidal artery. Now, how do you identify the anterior ethmoidal artery? Very simply, because this is the most important concern the young surgeons have. Whenever they are operating on the frontal sinus, the ethmoidal high roof of the ethmoid sinus, they are always concerned with one thing, which is the anterior ethmoidal artery. Now, there's nothing to worry about the anterior ethmoidal artery, because it is very simple and easy to identify it. Now, there are 4 points of how you can actually identify the anterior ethmoidal artery, very simple steps. So I'll count them one by one. There are total 4 points, 4 landmarks of how you can identify the anterior ethmoidal artery. The very first one is keep on following the orbital anatomy. Okay, I always stress on this point. This is the most easiest point where you can actually find the anterior ethmoidal artery very easily, is by following the orbital muscle anatomy. Okay, see, on all these scans, see, this is the area of the orbit. Just keep on following the orbit until you see the muscles very prominently. See, the muscles have started to appear over here in this region. Just keep on following them until and unless they are quite prominent. Okay, see, this area, they are quite prominent. This is the medial rectus. I'll give a close-up. This is a medial rectus. That's the superior rectus. That's the inferior rectus. That's the lateral rectus. Same on this side. Superior, medial, inferior, and the lateral rectus muscle. And you can see a small muscle over the most medial aspect. See up here, just above the medial rectus over here. That's the superior oblique muscle. That's the superior oblique muscle. Now, in previous scans, you just have to observe that. Sorry. You just have to observe that this is a medial rectus and that's the superior oblique. They are quite far away from each other. As you keep on going posteriorly, they come close to each other, and at one point they just almost touched each other. They see this area? they are almost touching each other, they are very close to each other, and this is the area which is called as the confluence area of the medial rectus and the superior oblique. Okay, so in this region where they come very close to each other is the area where the anterior ethmoidal artery is gonna exit the orbital lamina papyracea and enter the lateral lamella of the cribriform. So you see this area right over here? See this? That's the medial rectus and that's the superior oblique almost touching each other. And so you see this projection? There's a small bony projection occurring at the very level. A triangular nipple shape on the lamina papyracea. You see this? That's the area of the anterior ethmoidal artery coming out of the orbit. See this? That's the most posterior aspect of it. This is a proper canal. You cannot see it over here. So this is a beginning point. That's the posterior point. See this? That's a prominent triangular nipple-like projection, and you can see the canal quite clearly at the confluence of the medial recti and the superior oblique. And this is the lateral lamella, as I said a lot of times already. The vertical segment is the lateral lamella. This is the medial lamella. And see, it is piercing the lateral lamella over here to enter intracranially. So that's the anterior ethmoidal artery for you. So this is how you identify it by using the orbital anatomy. Now, the second most important point is second, third, and fourth. These are bony landmarks. Okay, the first point was the muscle anatomy. Now, the second, third, and the fourth point are going to be the bony landmarks of how you can identify the anterior ethmoidal artery very easily. So the first bony landmark, which is the second point, is the ground lamella. Okay, is the ground lamella. As I previously explained in this video, that the ground lamella is nothing but the middle 1/3 of the middle turbinate. Okay, this attachment to the cribriform was the anterior 1/3. Keep on following it. See, this is the anterior most aspect of the ground lamella, where this is still the main attachment. This is the cribriform attachment on of the middle turbinate being the anterior 1/3, but just anterior, this is the attachment of the lamina papyracea, which is the ground lamella. If you go behind, that's the proper ground lamella. So you cannot see the artery over here, but you can see the artery over here and quite prominently over here. So this is a posterior most aspect of the artery. This is a main aspect of the artery. So where was the ground lamella? This was just the beginning of the ground lamella, and this was the ground lamella proper. So always remember that the anterior ethmoidal artery is few millimeters. Now this is a 2 mm scan, so 2 to 2.5 to 3 mm. It is anterior to the ground lamella. Okay, so see, this is the ground lamella proper. This is the most anterior aspect, and see, this is the posterior most aspect of the artery. That's the main artery canal. So it is anterior to the ground lamella. So follow the ground lamella, look for the ground lamella skull base attachment while you're operating, and immediately anterior few mm to it will be the anterior ethmoidal artery. This is right in front of you. That's the ground lamella. See, that's the attachment of the ground lamella, is the skull base. Immediately anterior, see, one scan anterior. I'm not going too far ahead, I'm just going one scan. See, this is the ground lamella. Immediately one scan ahead is the artery, posterior most aspect. One scan even further, that is the artery proper. So exactly immediately anterior to the ground lamella is the anterior ethmoidal artery. Also, an easy way to remember this is the ground lamella behind is the posterior ethmoids, and ground lamella ahead is the anterior ethmoids. So the anterior ethmoidal artery lies in the most posterior aspect of the anterior ethmoidal cells. Okay, so that is very easy to remember. Now the second bony landmark is the bulla ethmoidalis. Okay, now first for that we need to locate where the bulla ethmoidalis actually is. So this was the agar nasi, this was the agar nasi, the one cell type cone agar. Now this is the most anterior aspect of the bulla ethmoidalis. Now that's the bulla ethmoidalis proper. That's the beginning of the bulla ethmoidalis. Keep on following the bulla ethmoidalis. That's the bulla ethmoidalis. The anterior ethmoids, that's the bulla ethmoidalis. See, huge cell of bulla ethmoidalis. That's the bulla ethmoidalis. Now, bulla ethmoidalis and ground lamella, how they are related. So they are related in a way that bulla ethmoidalis is always anterior to the ground lamella, and immediately behind the bulla is the ground lamella, and the space between the ground lamella and the bulla ethmoidalis is called as the lateral sinus or the sinus lateralis of Grunwald, also called as the retrobullar recess. So you can see here, that's the huge bulla, and immediately behind we go, this is the very beginning of the ground lamella, the main attachment still being on the cribriform but the very anterior aspect of the ground lamella. So this is the bulla ethmoidalis, the cell, and immediately behind is the ground lamella. See this? Now that's the ground lamella proper, and that's the small part of the bulla. So the space between the ground lamella and the bulla ethmoidalis is called as the lateral sinus of Grunwald, or also called as the retrobullar, that is behind the bulla recess. You see this area between the bulla and the middle turbinate, that's where the part of the retrobullar recess drains into. That is also called as the lateral sinus of Grunwald, or the sinus lateralis of Grunwald, where the drainage actually occurs through. So this is very important area to remember, the retrobullar recess, the suprabullar recess, the drainage of these two very recesses through the lateral sinus of Grunwald. Okay, so this is how the relationship of the ground lamella and the bulla is. So whenever a surgeon is opening the frontal sinus area, he does it using an intact bulla technique. Now we all know, we have all heard, we have all seen our seniors do it before, the intact bulla technique. Why we do the intact bulla technique is for only one reason: to keep the bulla intact and open the frontal, just to prevent the damage to the anterior ethmoidal artery. Why? Because see this was the area of the artery, that is the anterior ethmoidal artery, remember? So this was the bulla, the artery is not yet in the picture. This is a bulla, this is a bulla ethmoidalis, this is a main artery proper, this is a bulla ethmoidalis, and this is a ground lamella starting. That's the most posterior aspect of the artery. This bulla ethmoidalis protects the anterior ethmoidal artery anteriorly. See this? That's the bulla ethmoidalis, and that's the attachment of the bulla ethmoidalis up in the higher skull base. So the bulla ethmoidalis is anterior to the anterior ethmoidal artery. It acts as a bodyguard. It acts as a bodyguard to the anterior ethmoidal artery. So once you open the bulla, the anterior ethmoidal artery is wide exposed in the superior aspect. So in this case, as I can see, this is a bulla, the limit is only up to here, and this is a suprabullar recess, so the artery is quite exposed. So if you operate in this patient, you will see the bulla, but there will be a gap above the bulla called as a suprabullar recess, into which directly the artery will be seen running in a canal. So this case is quite difficult, because the bulla in this case will not be able to protect the artery from the anterior aspect. So this is called as the suprabullar recess area, in which the artery becomes more prone for injury. So that was the second bony landmark. The third bony landmark is the presence of a supraorbital cell. Now in this patient, I don't think so there is presence of a supraorbital cell as prominent. So if a case has a supraorbital cell or a supraorbital recess, the supraorbital recess is related to the artery, as in that the anterior ethmoidal artery. Say suppose for example there was a huge pneumatization over here following up to the artery. Suppose this is the arterial level, and still there would be a huge cell over here opening, shaped like a frontal sinus but not the frontal sinus. So that would be the supraorbital cell opening into the supraorbital recess. So immediately posterior or immediately caudal to the supraorbital recess or the cell, your artery will be lying down there. So those were the three bony landmarks and one muscle anatomy of the orbit landmark for your anterior ethmoidal artery. So, if your artery while surgery gets damaged on the medial aspect, it can cause a CSF leak because the artery enters into the lamina. See, this is the artery coming from the orbit. Now, the anterior ethmoidal artery is a branch of the ophthalmic artery. The ophthalmic artery is a branch of the internal carotid artery in the circle of Willis. Then the anterior ethmoidal artery, it is coming from the lamina papyracea medially in the posterior aspect of the medial wall of the orbit, along with the nasociliary nerve in the orbit itself, and in the orbit it enters the lamina, giving this projection called as the Kennedy nipple sign on the CT scan. Kennedy nipple sign. It enters into this canal. You see this? The canal is quite clearly evident over here. You see this canal over here? It enters this very canal, also called as the orbitocranial canal, and hits the lateral lamella of the cribriform. And this area where the artery pierces the lateral lamella is the most thinnest and the weakest or the most susceptible point in the skull base for injury. So any damage to the artery on the insertion of the lamina or the insertion of the entry of the lateral lamella of the cribriform can cause either damage to the level of the lamina. If it is injured here at the level of the lamina papyracea, it can retract back in the orbit, and as you can see, the orbit is bony from all sides. It cannot expand even 0.1 ml. It will immediately give a blinding effect, compression on the optic nerve. You see this? That's the optic nerve in the center, and muscles are on the periphery. This is the optic nerve. So if the artery retracts inside, this will be all full of blood without expansion. The optic nerve will be compressed over here from all sides, which will give to blindness in a span of 10 to 15 minutes into the patient. So that is what a risky complication. So that is why you have to prevent injury to the artery. So if you damage the artery towards the lateral lamella of cribriform, it can cause you a CSF leak. Now, as the artery enters into the cranial cavity, passing through the lateral lamella of the cribriform, it immediately gives a branch called as the anterior meningeal artery, anterior falcine artery, anterior Fox artery. These are all the names for the same artery, which supplies the Fox cerebri. Okay, after supplying the Fox cerebri, it continues back into the nasal cavity. See, the first part was the orbital part, second part was the canalicular part, third part was intracranial part. After giving the meningeal branch, it comes back into the nose, supplies the septum, supplies the lateral wall, supplies the sinuses, ethmoid sinus, anterior ethmoid sinus. Then again enters extracranially in between the dorsum and the ala of the nose, supplying there externally. So there was this first part, second part, third part, fourth part, and the fifth part outside. 5 parts of the anterior ethmoidal artery. You have to remember this always, being a sinus surgeon. Okay, so that was the anterior ethmoidal artery for you guys, simply explained in detail. Then moving further on, this is the area of the cribriform defect which I showed you earlier. So normally the defect is visible in this scan and this scan. So this is a 2 mm scan, so roughly the defect should be of around 4 mm, right? But in actual, when you're operating on the patient, the defect is always about 2 mm to 3 mm, or least 1 to 2 mm. It's just the soft tissue which appears to be widened, but the leak actually is around only 1 to 2 mm max to max. It's just a prolapse of the meninges over here, which gives you a widened prolapse effect. But in actual, the defect only ranges from around 1 to 2 mm. And the defect is only in the medial lamella of the cribriform, and the medial lamella of the cribriform is around roughly 1 mm max to max, or even less than that. So moving further ahead, as we saw that this is the ground lamella proper, the superior turbinate. Now we are entering into the posterior ethmoids. So the posterior ethmoids, that's the middle turbinate, inferior turbinate, maxilla. Now once we are in the posterior ethmoids, the maxilla, from the triangular shape, you see it's all triangular and huge here. Once we enter the posterior, it starts becoming oval. See, this is a scan which is showing you the oval maxilla. It starts becoming oval, and as you go behind, it becomes so oval and narrowed out, it starts to disappear. See, it's disappearing and it completely disappears posteriorly. Okay, so that was the change, first transition change. Second transition change is, look at the orbit. This is the anterior ethmoids. Look at the orbit. It is completely circular. Okay, it is completely circular. At the moment you enter, this is a posterior ethmoid. See, it is no longer circular. It becomes conical and compressed and narrow, and eventually fades out at the orbital apex area. This is the orbital apex area, and then see, there is no more. Now this becomes the superior orbital fissure and the cavernous sinus area behind the orbit. So that's the second transition. The third transition is the slope of the skull base. See, in the anterior skull base, it is sloped towards the center. It is kind of oblique in origin. See, it is oblique. See, it is oblique. See, the moment you enter the posterior ethmoid, this is the very beginning of the posterior ethmoid. See, it becomes flat. It is not oblique anymore. It becomes flat. See, it's a straight line. It becomes flat, completely flat. See, it's completely flat. Okay, that's the third change. Now, the fourth change is the thickness. The fourth change is the thickness. See, the anterior skull base by rule is thin. The anterior skull base by rule is thin, and as you go posteriorly, see, the thickness is so big. It is a very thick bone. As you go posteriorly, the density of the bone is increased, and it becomes thicker and thicker as you go posteriorly. See, it's all thick. That was a fourth change. Okay, so there are few transitions which occur when you enter from the anterior to the posterior ethmoids. So if at any point, if you are given any single scan and you have to identify whether it's posterior or anterior ethmoids, you can easily identify depending on these very 4 to 5 points of transition. Okay, and the fifth point of the transition is that in the anterior ethmoid, as you can see here, the cells are small. Okay, the cells are small and numerous, and as you go into the posterior ethmoids, the cells are huge and less in number. See, the cells are huge and less in number. That's the typical posterior ethmoidal cells for you. So these are total 5 points of transition from anterior to ethmoidal, posterior ethmoids, of how you can identify the anterior to the posterior ethmoids. Now, the most important aspect of this entire CT scan for a skull-based surgeon remains the area of the sphenoid bone. Now, to wind this up, we just have to look for the sphenoid sinus now. This carries a lot of importance, as a skull-based surgeon is always concerned with the sphenoid sinus anatomy. A fist surgeon will be concerned with all the sinus surgery, but a proper skull-based surgeon will always look for the frontal and the sphenoid sinus, as they are closely in connection to the skull base. So there are few points of how you identify the sphenoid sinus and whether it is not the posterior ethmoidal cells but actually the sphenoid sinus. Now I'll show you in very few simple steps, max to max 2 or 3 simple steps, you can identify the exact location of the sphenoid. Now just keep on following the area of the posterior ethmoids. See, this is the frontal bone, that's the orbit. Okay, that's the I'm giving you a multiple view over here. See this is the orbit area with the muscles converging and becoming narrowed out. And what is this bone? This bone, what is it? This is a frontal bone. See, this is a frontal bone. This is a frontal bone. This is the orbital plate. This is the orbital plate. That's the frontal bone. And what is this point called as? That's the pterion. See, the pterion. See, the entire bone is intact. See, the entire bone is intact, thick and intact. See, intact. The moment you see that the bone is not intact anymore from the pterion to the pterion. See this as a huge lapse of bony area over here. See, this is what? This is the lesser wing of sphenoid. See this? That's the lesser wing of sphenoid. And this marks the official beginning of the entire sphenoid bone. And this is the sphenoid body with the right sphenoid sinus, the left sphenoid sinus, the intersphenoidal septa or the intersphenoidal septum, dividing the sphenoid into the right and the left over here. This is the lesser wing of sphenoid. This is the greater wing of sphenoid. This is a body with the two sinuses. This is the intersinus septa. This is the septum, inferior turbinate, middle turbinate, superior turbinate. Okay. And this is the medial pterygoid plate, lateral pterygoid plate, the pterygoid body. So going behind further to make it clear. Now see, this is the lesser wing of the sphenoid, the flat horizontal lesser wing of sphenoid. This is a greater wing of sphenoid. This is the body of sphenoid with the intersphenoidal septum with right sphenoid and left sphenoid with one more septa in between the left sphenoid or the intrasphenoidal septa on the left side. This is the intersphenoidal septum, right and left, and this is the intrasphenoidal septa. And this is a separate perpendicular plate, or you can say this is the nasal bony septum separately. And see, this is the pterygoid body, medial pterygoid plate, lateral pterygoid plate, and this is much more clearer. This is much more clearer. See, this is much more clearer. So this is the first point of how you identify the sphenoid is by following the pterion to pterion. The moment the bone disappears on the lateral aspect, this is the lesser wing, and then you have the entire sphenoid bone in your vision. So this is the official start of the sphenoid. If I go one scan behind, see, it is still intact and it is just fading out. So what I can see here is the superior turbinate. See, remember, see this area? That's the superior turbinate. And we all know that superior turbinate and the septum in between is the sphenoid ostia, the natural sphenoid ostia also, which is, this is a choana. This is a choana, superior bony margin of choana, 1.5 centimeters above the choana. Between the septum and the superior turbinate lies the natural ostia of sphenoid. So this is the posterior most aspect of the posterior ethmoidal cell. Okay, and this here marks the very beginning of the sphenoid sinus. So this is how you differentiate between the sphenoid sinus proper and the posterior ethmoidal cells. This is a sphenoid sinus, and this could be the this is a posterior most ethmoidal cell, posterior most ethmoidal cell, and then this is the actual sphenoid sinus on both the sides. So this is the first point on how you actually identify the sphenoid sinus over here. The second point is you keep following the septum, the midline septum. See this? This is the septum right from the skull base up to the maxillary crest attachment. Keep on following. Same single septum vertical. Same single septum vertical. Now as you go posteriorly, see this? The thickening you can see. This is the rostrum of sphenoid. The thickening in the superior region of the midline septum is called as the rostrum of sphenoid. See this? That's the rostrum of sphenoid. And if you go behind one scan, see this now? This is one different area of the nasal septum posteriorly, and the thickened part is one different area in the sphenoid. Now this has become the intersphenoidal septum, and this has become the nasal septum. So this is how you identify that you have entered into the sphenoid on the CT scan. And this is the intersphenoidal sinus septal cell. See this? So these are the 2 points on how you identify whether you have entered the sphenoid or you're still in the posterior most ethmoidal group of cells. So I hope what I'm explaining to you, because if you keep a narrow and a close watch, if you keep a close watch on the sphenoid anatomy, you are definitely going to enter properly into the sphenoid only and nowhere else. Now, I was talking about this intrasphenoidal septal cell, okay? This is actually the right sphenoid over here. This is a right sphenoid, the right huge sphenoid. And what I was thinking here, this is actually the onody cell. This here is the onody cell. Now, why this is the onody? Because if you keep on following it, this septa extends way more posteriorly than expected. 1, 2, 3. So 3 scans the septa is extending. And see this? This is the onody cell. Now what is an onody cell? Onody cell is the posterior most ethmoidal cell pneumatizing, okay, which lies above. See this? This is a sphenoid proper which lies above and posterior and a bit lateral to the sphenoid sinus. So whenever there is a onody cell, it pushes the sphenoid sinus inferiorly more towards medially, because itself the onody is posterior lateral superior, so it pushes it inferiorly and medially. And in such cases, now this is the anterior clinoid process, this is the anterior clinoid process, and medial to the anterior clinoid process is the area of the optic nerve. See this? This is the anterior clinoid and this is the area of the optic nerve. This is the area of the internal carotid artery. See this bulge inside? See the fraise, see the shape of the fraise. See, the shape of my tip of the fraise elevator is coinciding with the shape of the bulge inside. That is the internal carotid artery bulge. Okay? See, that is the internal carotid artery bulge, internal carotid artery bulge, and this is the optic nerve bulge. And both of these bulges are seen in the onody cell. The optic nerve is in the onody, the bulge of the ICA is in the onody, and this is a sphenoid proper. So this is why it is very important to learn the CT scan, and before operating we should know that this patient has an onody. If you do not see the CT scan and just directly wash up and operate the patient and directly enter into the posterior most aspect of the sphenoid or ethmoidal cell and break it and enter into the sphenoid, and not knowing that there is an onody cell, if you open this onody thinking that this is still a sphenoid cell sorry, that this is a sphenoid cell, so thinking that this is a sphenoid cell or the posterior ethmoid cell, you can directly break this not knowing that this is an onody, and you can just directly injure the optic nerve and the ICA bulging into the onody cell, and that will be life threatening if you damage the internal carotid artery. If you damage the optic nerve, there will be blindness, and if you damage the ICA, it is a life threatening bleed. So this is why it is very important to know the anatomy of the onody on the CT scan before operation, and if you know that there is onody cell, you can take safety measures by opening cell to cell very carefully. So this is the importance of the onody cell and knowing the onody on the CT scan. So keep on following the anterior clinoid process. See, the bulge of the internal carotid artery and the optic nerve is becoming more obvious, and this is the onody cell now becoming narrowed out. And if you go more posteriorly, see the left sphenoid is very small and the right sphenoid is very prominent over here. Keep on following. You see this, the sphenoid. This is the posterior clinoid process. This was the anterior clinoid process. Okay, so this is the opening. This is a nasopharynx opening. This is a nasopharynx. This is the ischemic tube opening. See this? See this? This is the ischemic tube. This is the ischemic tube opening. This is the torus tuberous, the bulge of the ischemic tube, and this is a fossa of Rosenmuller. Deep to the fossa of Rosenmuller laterally is the internal carotid artery, the parapharyngeal internal carotid artery. So in case of skull base surgeries, you can access the
artery from this fossa of Rosenmuller by drilling the pterygoid plate. See, this is a pterygoid plate over here. By drilling the pterygoid plate, you can access the fossa of Rosenmuller and the artery. So keep on following. See this defect over here. This is a greater wing of sphenoid. This is the posterior most aspect of the sphenoid, posterior to the clivus region. Posterior to the clivus. This is clivus region. Posteriorly aspect. This is foramen ovale. This defect here is this is the foramen ovale, which transmits what? The mandibular nerve, the V3. This is foramen ovale, and this is transmitting V3 nerve, foramen ovale. Okay, that's the nasopharynx. Now, the last concept I need to teach you guys is how to identify the sphenopalatine foramen, the sphenopalatine canal, the inferior orbital fissure, the superior orbital fissure, the cavernous sinus region, okay, and the two most important nerve anatomy, that is the V2, that is the foramen rotundum, and the Vidiian canal. Okay, so I'll start off with the sphenopalatine foramen. Now follow the posterior most aspect of the maxilla from start. You keep on following the maxilla, follow it, and you reach the posterior most aspect of the maxilla. Once you start seeing the posterior most aspect of the maxilla, that is the medial pterygoid, the lateral pterygoid plates, see this area, just keep on following. This is the inferior turbinate, this is a middle turbinate. Okay, see this is a posterior this is a sphenoid sinus, this is a sphenoid sinus. Now sphenoid sinus is in the sphenoid bone, and this is the perpendicular plate of the palatine. See, listen to me very carefully. This is sphenoid bone, okay, lesser wing, greater wing, sphenoid body, and this is the maxillary posterior most aspect. Now the medial wall of the maxilla posteriorly is the perpendicular plate of the palatine, and this is sphenoid above. So sphenopalatine canal or the foramen, see, sphenopalatine foramen between these two on the posterior most aspect. Now this is the perpendicular plate of the palatine bone. Okay, this is the perpendicular plate of the palatine bone. Now the perpendicular plate of the palatine bone has two processes. One which is going superiorly, which is called as the orbital process. See, this is the inferior orbital fissure, and this is the orbital apex. See this, follow the orbit. This is the orbit. Keep on following the orbit. This is the orbit, keeping narrowed. Okay, this is the most posterior aspect of the orbit, and that is the orbital apex. This is the region of the orbital apex. That's the region of the orbital apex. And now see the bulge of the internal carotid artery and the optic nerve. Just anterior to it is the orbital apex, and that's the optic nerve. So this is the orbital apex, and just immediately below this is what do you see this? What do you see here? This is the inferior orbital fissure. This is the orbital apex, that is the orbit, and this is inferior orbital fissure. This is the inferior orbital fissure, and immediately to the inferior orbital fissure medial is the sphenopalatine foramen. So it's very easy. You locate the inferior orbital fissure, you locate the sphenopalatine foramen automatically between the sphenoid and the palatine bone. So the gap in this region, you see this proper gap, that's the sphenopalatine canal, where you can see the sphenopalatine artery coming, where you have to ligate in cases of endoscopic sphenopalatine artery ligation in case of recurrent epistaxis, which is uncontrolled epistaxis. See, this is the inferior orbital fissure, sphenopalatine canal, foramen. Now see, that was easy to identify, right? So this is how you identify the canal, the inferior orbital fissure. You keep on following the orbital apex. The moment you see the internal carotid artery bulge, that's the area of the cavernous sinus, because lateral to the sphenoid on both sides at the level of the internal carotid artery is the cavernous sinus. So if this is a CT scan, mostly for the bony anatomy, but if you take an MRI scan at this very region, you will see the cavernous sinus on both the sides. Keep on following the cavernous sinus. Posteriorly, you can see the cavernous sinus. Okay, so that's the region of the cavernous sinus, you can see. and that's the optic nerve, the anterior clinoid process. Yeah, that's the cavernous sinus. So I have explained you the area of the sphenopalatine artery, the sphenopalatine foramen, the inferior orbital fissure, and how to locate the cavernous sinus easily. Now I was talking about the perpendicular plate of the palatine bone. Okay, the perpendicular plate of the palatine bone has two processes. One which is directly going up. See, this is the orbital area. One which will go directly up like this towards the orbit. That is called as the orbital process. That is called as the orbital process. And another process which goes horizontally backwards is called as the sphenoidal process. See, sphenoidal process. So one is orbital process, one is sphenoidal process. So these two processes, they form a notch in between. The orbital process and the sphenoidal process forms a notch in between, and this very notch is guarded superiorly by the body of sphenoid. See, this is this bone, this is the sphenoidal process. One which is going above is the orbital process. I can show, yeah, this is the area. So orbital process, sphenoidal process forming a notch, and the notch being guarded superiorly by the body of sphenoid, so forming a foramen altogether. And this is a very foramen you can see over here right now. That's the foramen. That's the foramen which transmits which transmits the palatine nerve and the sphenopalatine artery, which is a branch of the maxillary artery, continuation of the maxillary artery, internal maxillary artery. Okay, so that's the main artery for the epistaxis. So in case of epistaxis, you elevate the submucosal flap on the posterior aspect of the maxilla, identify the canal, and just ligate the artery. Okay, so that was the inferior orbital fissure, the cavernous sinus, the sphenopalatine foramen, the sphenopalatine canal, the sphenopalatine artery, the continuation. This basically is the region of the pterygopalatine fossa. See, this is a posterior most aspect of the maxilla. This is the posterior most aspect of the maxilla. What is behind the maxilla? What is behind the posterior wall of maxilla? This is pterygopalatine fossa. Posterior wall of maxilla, behind is the pterygopalatine fossa. Simple. And lateral to the pterygopalatine fossa is what? The infratemporal fossa. The infratemporal fossa. Okay, that's the infratemporal fossa. So this is how you locate all these complicated structures once you know the basic anatomy. These very complicated structures becomes very easy for you to identify on the CT scan. So on the CT scan, step by step, you have to localize all these complicated areas in case of tumors or JNAs. So mostly in the JNA, the pterygoid body will be all eroded because that's the origin of the JNA. This is a very area of the pterygoid body. So it will erode, come from the sphenopalatine canal. See, I'll show you very easily. See this? That's the area of the IOF. This is the area of the canal of the sphenopalatine foramen. So this is a pterygoid region. If you go posteriorly, see this pterygoid body? That's the pterygoid body. This pterygoid body will be all eroded, and it will come from the sphenopalatine canal into the foramen, into the nasal cavity. It may go upward into the sphenoid. It may go through the inferior orbital fissure into the orbit. So if there is a JNA, the juvenile nasopharyngeal angiofibroma, if arises from the pterygoid body, the wedge, it can enter into the nasal cavity via the sphenopalatine canal. It can enter into the sphenoid via this bony partition over here. It can enter the orbit via this very inferior orbital fissure because it's very nearby, and so on. So the JNA enters through the inferior orbital fissure first. So yeah, and the last and the most important thing is the Vidiian Canal and the Foramen Rotundum. See, as you can see, as you keep on going posteriorly, this is the area of the proper pterygoid body. That's the pterygoid body, and that's the medial pterygoid plate, lateral pterygoid plate, medial pterygoid plate, lateral pterygoid plate. This is a coena proper. This is proper coena. The lateral boundary, which is formed by the medial pterygoid plate, clearly can be seen here. So in cases of coenal atresia, it is this medial pterygoid plate which is excessively thickened out in cases of bony or the mixed coenal atresia, where you have to drill the medial pterygoid plate to access the patency of the coena. So coming back to the sphenoid sinus, this is the pterygoid body. Now this is a sphenoid. Now listen carefully. How to identify the V2 and the Vidiian canal. See, this is the pterygoid body. See, this is a pterygoid body which is inferior lateral to the sphenoid floor. Now this is the area where we operate on the sphenoid sinus and gain an entry, and there is a bony partition wall all the way over here which we have to remove, and there will be the posterior septal branch of the sphenopalatine right over here. So when you open up the entire anterior bony wall of the sphenoid, you get an access to the floor of the sphenoid and to the inferior lateral region of the floor of the sphenoid in the pterygoid body itself. In the pterygoid body, see, remember, see, it's right in front of you. This is a sphenoid and this is a floor of sphenoid. This is a pterygoid body. Inferior laterally at the level of the floor of sphenoid in the pterygoid body, you see these two structures. You see these two structures, 1 and this is 2. This inferior medial structure is called as the Vidiian canal, and this superior lateral structure is called as the V2, that is the foramen rotundum, the maxillary nerve of trigeminal division. Okay, so this is the Vidiian canal where the Vidiian nerve runs. This is the V2, that is the foramen rotundum. See how easy it is to identify once you know the basic anatomy. So these two foramen are present into the pterygoid body on the inferior lateral aspect of the floor of the sphenoid sinus, and the one which is superior lateral is the V2, and one which is the inferior medial is the Vidiian canal. So it goes by the saying Vidiian is median. Okay, so this is a Vidiian, so Vidiian is median. Very simple to remember. If you ever forget, just rhyme it. Vidiian is median, okay, and the remaining lateral one is the V2. So this is how you identify. So keep on following it. So in case of, so this is a Vidiian canal. See, this is a prominent circle. That's the Vidiian canal. This two this is two prominent structures, yeah, circular. That's the Vidiian canal traversing the entire course. Now, there are many more things to say on this Vidiian canal, the foramen rotundum, the relationship of the Vidiian canal with the internal carotid artery as a roadmap for the ICA, and the foramen rotundum being the lateral most limit of the skull base surgery drilling in cases of lateral recess of sphenoid. Now, this sphenoid does not have a lateral recess. Now, what is lateral recess exactly? So, if the sphenoid is excessively pneumatized into the greater wing of sphenoid here, or into the pterygoid body over here. See, this is a Vidiian canal. This is a Vidiian canal, and this is the foramen rotundum. In between is the pterygoid body. So if this pterygoid body gets pneumatized, or this greater wing of sphenoid gets pneumatized, it's called as the lateral recess of sphenoid. And if it is in the pterygoid body, the lateral recess, it will, see, if the pneumatization occurs here, the V2 will be high up and the Vidiian canal will be lower down here, giving a huge gap in between the two in cases of lateral recess. Okay, so this is a basic anatomy of the entire coronal sections of the CT PNS, which I just explained it to you. So if next time you have to go through a CT scan, I am very sure that you guys are now going to clearly basically read the entire CT scan without any difficulty. And in future videos, in due course of time, I'll be collecting CT scans from all sorts of other pathologies, be it AC polyp, the ethmoidal polyposis, any skull base defect, or the GNA, or any tumor, benign tumor, nasopharyngeal carcinomas. All these cases, how they affect the anatomy of the CT scan and how the structures are affected. So once you learn how to read the normal CT scan, only then you will be able to read the CT scan in case of a pathology. So how the GNA disturbs the anatomy, how the ethmoidal polyposis, how the allergic fungal sinusitis changes the anatomy within the CT scan, and how in that case you can identify the CT scan I will teach you everything on the future videos in due course of time. I'll keep on uploading the videos so that you guys get to learn the maximum where you can. So just keep on subscribing to my channel, keep on learning, keep on sharing. I will try to teach you maximum whatever possible in cases of skull base surgeries and sinus surgeries to my level best. Okay, so keep on subscribing. See you soon. Take care.